Good evening, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us. We have top educators, quality content, and we'll give you a great learning experience. So, guys, let's crack NEET PG. A little about me. I've done my MBBS from Father Muller Medical College, Mangalore. I'm Dr. Sasha. I've done my MD in anesthesiology from Father Muller Medical College, Mangalore itself. I have 2 publications and 1 paper presentation in the field of anesthesiology. I have been working and teaching in Bangalore for the past 2.5 years. Our today's topic will be neuromuscular blocking drugs, that is the non-depolarizing muscle relaxants part 2. So I dealt with one part yesterday. I'll be dealing with the second part today. I'll be giving a brief overview. We'll go through the slides briefly of yesterday and we shall continue our class, the rest of the class today. So guys, Unacademy is one of India's largest learning platforms where you can get plus subscription and you have access to unlimited live and recorded courses from India's best educators. So guys, get your subscriptions quickly. Don't waste time, hurry. So what are you going to get out of Unacademy? So you have your daily live classes where you can chat with your educator, engage in discussions, ask your doubts, clear your doubts. There are answer polls, and all this is happening while your classes are going on. These are not on the YouTube classes, these are on our special classes and our subscription classes. So subscription is where you have to subscribe, and the special classes are free classes which you all can access, where you all can actually put forth your doubts and we will clear your doubts then and there. So you can, and where you can chat with your educator too regarding your doubts. Now in a coaching class, what happens is all this is not possible. You cannot clear your doubts then and there because there are so many students, so many doubts, plus there is so much of time that you waste while traveling to these classes also, right? Energy, time, this is all saved by these online Unacademy classes because you're sitting at home, you're taking wherever the comfort of your locality, and you're taking your classes, you're clearing your doubts. These are structured courses. Okay, these are all in line with your exam syllabus and help you best prepare for it. So these are all researched and the topics are prepared, the topics are up to date. It is all in line with the upcoming NEET PG exam. So you have your live tests and quizzes where you can evaluate your preparation because we have regular mock test quizzes, and this will help you get a detailed analysis on your performance. So in between classes, of course, we do conduct tests and quizzes so that you all become aware and it becomes easier for you all also. And it gives you an update as to your progress and helps you prepare again in a structured manner. You have unlimited access. One subscription can get you access to all our live and recorded courses to watch from the comfort of any of your devices. So like I said, you are taking the classes from your comfort, whichever locality is comfortable from you, whether it is at home or whether it is your hostels. You can take your classes from there. There are live and recorded classes, so you can fall back on your classes if you miss any. And this is all from the comfort from your devices, whichever is comfortable for you. These are some of our top educators. Dr. Nikita Nanwani, she's a NEET PG mentor for radiology as well as mnemonic and concept focusing on must-know topics. Dr. Mohammad Azam, Dr. Divish Mishra, Dr. Preeti Sharma. Unacademy offers you all a variety of 19 courses, as you can see, which if you subscribe, you can access the special classes, YouTube live classes. So helps you cover all these 19 courses. These are some of the ongoing courses on our platform, like from the respiratory system, pathology, larynx, cardiovascular surgery, GI surgery, neurophysiology. Now guys, coming to the subscription part, this is what I want to discuss with you all. So there are, as you can see, 5 types of subscriptions, right? NEET PG is a very vast, like I just said, 19 topics are being covered, 19 subjects, not even topics, 19 subjects are being covered. Each subject is so vast. You have to study so much, you have to cover so much of reading to do. 1 to 6 months is not practical. It is not possible in this short period of time. So I highly recommend the 12 and 24-month subscriptions, as these are give you time to prepare, more structured your studying can be, and higher chance of you clearing your exam. And also it is more economical. So coming to that fact, it is one subscription that you have to take. So if you take a 3-month subscription or a 6-month subscription, once the time is over, if you want to fall back, if you want to go back to the classes, you cannot access it. You need to pay again. You need to go through those the tests that are regularly given to you all, to undergo them. You'll have to pay again. But whereas with your 12 and your 24-month subscriptions, you have you can always, you have a whole year, 2 years to give your, you can keep undergoing those tests. It's a good practice for you all, plus it is a more structured form in 12 and 24 months. So guys, use my code as you can see at the bottom of the screen, SASHA, and avail 10% discount. So guys, subscribe fast, use my code, and you will get your discounts. Now, like I said, the 24-month subscription too is very attractive, and so use my code as you can see at the bottom of the screen, SASHA, and guys, 10% discount. Subscribe fast, don't waste time, start preparing. Okay, so coming to the topic, neuromuscular blocking drugs, the non-depolarizing muscle relaxants. So neuromuscular blocking drugs principally act by interrupting transmission of nerve impulses at the neuromuscular junction. The classification is into depolarizers and non-depolarizers. This is just of yesterday's class, just a brief revision. Depolarizers as a succinylcholine, they have an agonistic action at the neuromuscular junction. That is, they mimic actions of acetylcholine. So they bind to the receptor, produce the acetylcholine receptors on the muscle. They produce a brief muscle contraction followed by paralysis. The paralysis occurs because of continued depolarization, and the receptors cannot come back to a resting phase. Hence, there is paralysis. Non-depolarizers, the mechanism of action. These are the non-depolarizers. I will come to the mechanism of action. That is your steroidal compounds based on the chemical structure: steroidal, benzyl isoquinoline, phenolic ether, and strychnose alkaloid. Steroidal are your pancuronium, vecuronium, rocuronium. Benzyl isoquinoline are your atracurium, cisatracurium, and vecuronium. Based on the duration of action, they are classified as long-acting, intermediate acting, short-acting, ultra-short acting. Long acting is basically your pancuronium. Intermediate are all your rocuronium, atracurium, cisatracurium, vecuronium. Short acting is your mivacurium and rapicurium. Now the mechanism of action. So these are competitive antagonists, and these competitive antagonists basically the competitive antagonist, as you can see, these are competitive antagonists. They bind to the acetylcholine receptors. It needs to bind to only one alpha subunit to produce blockade, because acetylcholine ideally has to bind to 2 alpha subunits to produce muscle contraction, but these drugs need to bind to only 1 alpha subunit to produce blockade. So once they bind, there is no conformational change seen in the acetylcholine receptor, no ion channel opening, and hence there is no end plate potential developing. As a result, neuromuscular blockade occurs. Now competitive antagonist, that is, it competes with acetylcholine at the receptor. Now this is the sequence of muscle blockade, that is your face, jaw, pharynx, larynx, respirator, diaphragm, trunk muscles, limb muscles get blocked in this order. The recovery after neuromuscular blockade is also in this sequence. Now, actually, the dose to block the diaphragm and the muscles of the larynx is usually 1.25 to 2 times the adductor pollicis. That is, if you go by the potency of the drug. But in spite of this, the blockade is faster at the diaphragm and the laryngeal adductors. This is due to a rapid equilibration between plasma and the effect compartment. That is, it depends on the blood flow rather than the intrinsic property. So basically, the blood flow is important in determining the blood flow. The muscle blood flow is important in determining the onset and offset time. The pattern of blockade, the corrugator supercilii is the black pattern of blockade is very similar as the larynx, diaphragm and abdominal muscles, and hence one by monitoring the pattern of blockade, one can predict the quality of tracheal intubation. These are some characteristics of non-depolarizing muscular blockers. That is, they prevent acetylcholine from so these are some of the characteristics that I will be dealing with in my next class. That is, decrease in twitch, they cause a decrease in twitch sensation, single twitch stimulation, fade during repetitive train of force stimulation, and post-tetanic potentiation. These will be dealt in the next class, which is tomorrow at 7:30 p.m. Pharmacokinetics, they are highly ionized and water soluble at physiological pH. They are quaternary ammonium compounds, which makes them highly water soluble and do not cross the blood-brain barrier. Most of them undergo renal and hepatic elimination. The dosage, basically the speed of onset is inversely proportional to the potency of the neuromuscular blocking drug. A high ED95, that is the effective dose of the drug that produces a response, basically depression of twitch in 95% of the individuals. These are low potency drugs, that is lesser quantity of the low potency drugs, that is more quantity of the drug is required to produce a given effect. These have a rapid onset of effect and vice versa. So usually twice the ED95 is the dose to facilitate tracheal intubation. There's a priming dose is basically just before the intubating dose, a small about 20%, 10 to 20% of the neuromuscular relaxin, non-depolarizing relaxin, can be given, followed by, after a duration of about 30 seconds, 60 seconds, you can give the remaining intubating dose, and within 90 seconds intubation can be performed. Usually 3 minutes are required. So by this priming method, within 90 seconds intubation can be performed. Now metabolism, basically I will come to the chart. So metabolism of succinylcholine is by plasma choline esterases. Vecuronium undergoes metabolism primarily in the liver and also in the primarily in the liver and minimally by the renal. It's metabolite 3-hydroxy, all three metabolites are active, but 3-desacetyl vecuronium is the most active, and it is 80% as potent as vecuronium. It undergoes renal elimination and can accumulate in ICU patients. Pancuronium is long acting, primarily eliminated by renal and to a lesser extent by liver. Its main metabolite is 3-hydroxy, 3 metabolites, but only 3-hydroxy is active. Rocuronium is primarily by the liver. Atracurium undergoes Hoffman elimination and ester hydrolysis. And Vecuronium, again like succinylcholine, is degraded by plasma choline esterases. The adverse effects are some of the autonomic effects, which can cause hypotension, as well as autonomic effects are not very common and usually only seen with pancuronium tachycardia. Due to the vagolytic action, and this can be used in a positive manner. That is, it can be in opioid anesthesia. Pancuronium is used to counteract the bradycardia caused by opioids. Histamine release, mostly seen with atracurium and vecuronium. It's a short duration, it is dose related and insignificant in healthy patients, and tachyphylaxis develops. Respiratory effects, non-depolarizing muscle relaxants have activities at M2 and M3 receptors. M3 block leads to bronchodilation, M2 block leads to bronchoconstriction. Also, allergic reactions can be seen. Now coming to today's class, that is the remaining of the non-depolarizing, about the non-depolarizing muscle relaxants. So coming to the drug interactions. So Firstly, as you can see on the screen, antibiotics. So your antibiotics like your aminoglycosides, your tetracyclines. So your aminoglycosides, they bind, they basically uh, they have a they potentiate the non-depolarizing muscle blockade. This happens by a presynaptic as well as a postsynaptic mechanism. That is, presynaptically they inhibit acetylcholine release, and postsynaptically they potentiate binding the non-depolarizing drug action. Tetracyclines, on the other hand, have only a postsynaptic action. Now coming to your anticonvulsants. So anticonvulsants like phenytoin, carbamazepine, they actually have an inhibitory effect on the non-depolarizing blockade. So anticonvulsants basically, why it is they so what happens is more drug needs to be given, and the interval is also reduced. That is, between maintenance doses the interval is decreased, and more amount of, and hence more amount of drug is administered to the patient. Now why does this occur? So this occurs because of one hypothesis is binding to like alpha 1 glycoprotein. So basically your protein binding, and also because of upregulation of receptors. That is, there is upregulation of receptors is, that is, there is expression of your gamma immature receptors, gamma and alpha 7 receptors, and hence there will be more blockade because more number of receptors, and hence these, as a result the blockade will be decreased because of upregulation of the receptors are not available, as well as alpha 1 protein binding of the drug, and hence decreased amount of the drug is available. So they have, anticonvulsants have an inhibitory action. uh, Now coming to your dantrolene. So as you can see, antiarrhythmics potentiate neuromuscular blockade like quinidine, calcium channel blockers, because they block the calcium channel, and hence actually block neuromuscular contraction, because calcium channels are needed for acetylcholine release, stimulation of calcium channels needed for acetylcholine release, which is these calcium channels block, and hence potentiate neuromuscular blockade by non-depolarizing drugs. Of course, the cholinesterase inhibitors also can potentiate, though they are used to reverse the blockade. Actually, they are used to reverse the blockade, and hence they have a depressive effect, but they can also potentiate, that I will deal with later. Now, dantrolene, which is used in the treatment of malignant hypothermia, basically it potentiates the effect of non-depolarizing drugs, because dantrolene, its action is on the calcium. It inhibits the calcium within the sarcoplasmic reticulum. So it is not a direct action on the calcium channels, but still it has an inhibitory but still it inhibits calcium, and hence depresses muscle depolarization and muscle contraction, and hence has a positive effect on the neuromuscular blocking drugs. Inhalation anesthetics I'll be coming to. Your local anesthetics also potentiate because they block the sodium channels, and hence they potentiate the effect on non-depolarizing blockade. Now your magnesium sulfate also potentiates. So magnesium basically has again a presynaptic effect as well as a postsynaptic effect. So postsynaptically it inhibits depolarization. Basically, it has the property of inhibiting depolarization, inherent property, as well as presynaptically it binds to the receptors. It inhibits, basically presynaptically inhibits the calcium channel, and hence as a result inhibits acetylcholine release. Uh, then your lithium carbonate. Lithium is also known to potentiate the action. So lithium is very similar to, it potentiates, stimulates the potassium channels. It leads to stimulation of the potassium channels. As a result, the sodium channels are basically blocked, and as a result, it prevents your depolarization. It inhibits depolarization. So it potentiates the action of the neuromuscular blocking drug. So now when mixtures, so coming to the mixtures of when you mix two non-depolarizing muscle relaxing. So basically when mixtures of two chemically related like two benzyl isoquinolenes, that is your Vecuronium and Atracurium, they are, so when two chemically related non-depolarizing muscle relaxants are mixed, it is considered additive. But when mixtures of two structurally dissimilar drugs are mixed, it is considered synergistic. Okay, here the action gets added, here it is just combined together, it is synergistic. Approximately 3 half-lives are needed for clinical changeover, that is for the duration of the blockade to take on the characteristics of the second drug. So after giving the second drug, so that's 90, it requires 3 half-lives of the first drug before the action of the second drug comes on, that is the for 95% of elimination of the first drug. So like I said, the inhaled anesthetics actually potentiate the relaxant effect. That is desflurane more than sevoflurane more than isoflurane. This is the halothane, and finally your opioid and nitrous oxide anesthesia. So greater muscle relaxing effect of less potent inhalation. So these are less potent, desflurane, sevoflurane. These have greater, this is the decreasing order of the relaxing effect. In decreasing order of the enhancing the relaxant effect, and these are less potent. So the less potent agent has greater muscle relaxing effect because of their larger aqueous concentration, hence they reach the effect site quickly. So the interaction is thought to be pharmacodynamic, that is it has a central effect by inhibition of postsynaptic nicotinic acetylcholine receptors, as well as augmentation of antagonist affinity at the receptor site. So it augments the drug, it inhibits the receptor, as well as it has a central effect. Now the effect of temperature. Temperature basically hypothermia prolongs blockade. Okay, so hypothermia as such is said to decrease hepatic and renal, it's said to decrease hepatic and renal metabolism, and it, like over here, it delays excretion. So it decreases hepatic and renal metabolism, as well as delaying clearance of the drug is delayed. As a result, more drug is available, because so the duration is prolonged because of decreased metabolism and decreased excretion, delayed clearance. Now coming to the those were some of the drug interactions in brief, uh, about how it brings about the drug interactions. I'll go over them again towards the end of the class. Now coming to the special populations. Now the pediatric population, the effect of these non-depolarizing muscle relaxants on the pediatric population. So basically maturation of the neuromuscular junction occurs after the first 2 months of age. At the so till 2 months of age, in a neonate, basically it is immature neuromuscular junction. So when maturation occurs, the gamma receptor is converted to the epsilon receptor. So as you can see here, the gamma receptor to the epsilon receptor, but this occurs after the first 2 months of age. Infants, neonates have a large volume of distribution. It is a well-known fact. Infants have a large volume of distribution. This is because of the increased water content and the small size. So as a result, actually infants require only 20 to 30% of the dose, okay, to produce an effect. But because of the large volume of distribution, the dosage should not be decreased. Because why? Because like I said, 20 though they require a lesser dose, but because of the large volume of distribution, if this lesser dose is given, the effect will not be there. Relaxation will not occur because the dose gets diluted. Hence, dosage should not be decreased in infants and neonates because of the large volume of distribution, even though a lesser dose is required. So, basically, there is dosage, there is no adjustment in the initial, in the dosages there is no adjustment. Okay, then onset is faster. Now why is onset faster? Basically this is because of their circulation. They have a very high cardiac output as compared to adults. Okay, so the basically the equilibrium between the plasma and the effect site is very rapid, so their onset is faster as compared to adults. They require less frequent dosing. Now why is this? So they basically their hepatic and renal, like I said, the main mechanism of clearance is by hepatic and renal. So the hepatic enzymes are poorly developed, renal system is poorly developed, not yet fully developed. Hence longer clearances, longer elimination half-life. So the maintenance dose, that is your doses in between, need to be not decreased. Dosage does not change, but the interval needs to be increased. So your maintenance dose, basically your dosage interval is increased. Dose is unchanged, but dosage interval is increased and onset is faster. Now in the older patients, so various physiological and anatomical changes occur with age, right? So basically with age you will see there will be decreased renal, hepatic activity, basically your blood flow and enzyme activity. Then there will be the circulation is decreased, that is more prolonged time for circulation because the cardiac output is decreased. Then you have at the neuromuscular junction, basically the effects are decreased acetylcholine release because decreased storage in the vesicles, um, decreased number of receptors at the neuromuscular junction, decreased in folds in the membrane, all these and decreased sensitivity of the receptor to acetylcholine. So all these factors can be seen. These are the which contribute to the various changes in the older patients. So potency is unaltered, that is you do not have to adjust the dose of the drug. Onset can be delayed. So again, these are because of circulatory factors. Your cardiac output is decreased, so there is decreased equilibration. There's more time for equilibration between the plasma and the effect site. Unlike in pediatrics, where there is increased cardiac output, so between the plasma and the effect site, equilibration is pretty quick. So the onset is faster. Here it is opposite. Now, prolongation of the duration of action, decrease in dosing. So these are pharmacokinetic factors like I explained earlier. Because of decreased renal and hepatic blood flow, decreased hepatic and renal enzyme activity, decreased glomerular filtration. As a result of this, the duration of action is prolonged, and hence the dosing interval has to be increased, and the subsequent doses after the initial dose have to be decreased. Now, atracurium and cisatracurium have a slight prolongation due to increased volume of distribution. So, these atracurium and cisatracurium basically do not undergo organ dependent metabolism, but the duration of action is still prolonged in older people because there is increased volume of distribution. As a result of dilution, there is more time for clearance to occur and their action is prolonged. Butyrylcholine esterase activity is decreased because the hepatic activity is decreased, but it is not very significant. But still, the doses of mivacurium and succinylcholine, they don't need to be adjusted, but it is just, it is not significant, the decrease in these, it does not significantly impair the activity of the drug, but the activity is decreased. In obese patients, now in obese patients, basically, most drugs, normally in normal patients, the dosages are calculated based on total body weight, that is your normal weight. Yeah, but in obese patients it should be calculated based on the ideal body weight. This takes into consideration basically your height, and it has a constant which is related to your age constant. Okay, so it basically takes into consideration your lean body mass. So many studies showed that when dosages were calculated on total body weight, in obese patients, always the dose was very much increased. As a result, it led to prolongation of the neuromuscular blockade because it was taking into consideration basically more fat rather than rather than the muscle mass. Hence, the dosages should be calculated based on ideal body weight because it takes into consideration the lean body mass based on the age constant and the height. For a particular height of age group, that's how it is calculated. For a particular age group that have a constant height, the ideal body weight is usually this much. The formula is based on that, and it takes into it excludes basically the fat obstacle that is seen in obese patients, and it calculates the dose based only on the lean body mass. So this avoids prolonged recovery of the blockade by taking into account the unchanged muscle and unchanged volume of distribution. So actually the volume of distribution and muscle mass is not changed, but in with total body weight, this is over calculated because of the fat content. Severe renal disease. So like I said, they're quaternary ammonium compounds, these non-depolarizing muscle relaxants, and they are hydrophilic, ionized at a pH of 7.4 and poorly bound to plasma proteins. So the predominant pathway of elimination is glomerular filtration. This is important. This is the predominant pathway, a little part by the liver too. So now decreased in renal failure, basically there's decreased elimination of the drug and the metabolites, and hence there can be a prolonged duration. Only Atracurium, Cisatracurium and Vecuronium are independent of this. So Atracurium and Cisatracurium basically undergo Hoffman elimination, but the metabolite of Atracurium, basically laudanosine, which undergoes renal elimination, is produced. But laudanosine, the amount that is produced even while giving infusion in in ICU patients, it does not have any adverse effect on the uh, the it does not have any adverse effects. So the laudanosine in clinically used concentrations does not produce any adverse effects. So, but the because of the prolonged because the primary pathway of elimination is glomerular filtration. Hence, the amount of drug has to be decreased in renal failure. Otherwise, there will be prolonged duration of action. Now, succinylcholine is known to release potassium, right? Because of fasciculation, 0.5 milliequivalents is the usual potassium that is released, right? But in these renal failure patients, usually the serum potassium will be high because of the inherent condition of the disease. But succinylcholine is not contraindicated in these patients if plasma potassium concentration is normal. So even though it releases potassium, it does not predispose to hyperkalemia if the plasma potassium concentration is normal. Now hepatobiliary disease. So in hepatobiliary disease, there is a delayed onset of action. You can delayed onset of action and resistance to non-depolarizing muscle relaxants is seen. Basically, the volume of distribution is increased in cirrhotics. This contributes to this prolonged duration of action, and the volume of distribution is increased. This contributes to the delayed onset of action and resistance to non-depolarizing muscle relaxants. Your Atracurium and Cisatracurium, like I said, Hoffman's elimination, Atracurium also by esterase hydrolysis. The clearances are still slightly increased because of the large volume of distribution. Okay, so even though they undergo a different elimination, the plasma clearances are still slightly increased. So basically, along with volume of distribution, of course, the hepatic microenzymes are also injured, which leads to the delayed onset and resistance to non-depolarizing muscle relaxants. As a result, the dosages again have to be decreased in these patients accordingly, based on the mode of elimination of the drug. Now, butyrylcholine esterase activity is decreased because of decreased synthesis. So basically, butyrylcholine esterase is synthesized in the liver. So this activity is decreased because of damage to the liver. So the activity is decreased. Hence, clearance of Vecuronium and succinylcholine is decreased. Hence, dosages need to be decreased. Now, in burns patients. So, coming to burns patients, burns basically, what happens in burns patient is there is receptor upregulation. Okay, that is, there will be expression of fetal receptor and fetal immature receptors, which are the gamma receptor and the alpha 7 receptor. So whenever these receptors are very sensitive to succinylcholine but are resistant to non-depolarizing muscle relaxants. Why are they resistant? Is because they are resistant to non-depolarizing muscle relaxants and very sensitive to succinylcholine. The degraded product of succinylcholine, that is choline, can also bind with strong affinity to these receptors and produce depolarization and blockade. But they are resistant to these non-depolarizing muscle relaxants, the binding of these. Basically, they are resistant because in the alpha 7 mature receptor, there are 7 alpha receptors. So even if the depolarizing muscle relaxant binds to 2 of these receptors, there are still 3 receptors to which acetylcholine can bind and bring about an action. So this brings about the resistance to the non-depolarizing muscle relaxants. Then, but the problem with choline is the hyperkalemia. So the hyperkalemia seen with burns patients is basically 30. Normal is 0.5 milli equivalent per liter. With these burns patients, you can see the hyperkalemia of 13 milli equivalent per liter. So high chance of predisposition to hyperkalemia. The cause is not known. So this is usually seen after the first 24 hours. So in the first 24 hours, it is safe to give succinylcholine. For 48 to 72 hours after the burn, it is not advisable to use this drug. It is better to use a non-depolarizing muscle relaxant. And this risk of hyperkalemia persists for 1 to 2 years. So after a burn, for 1 to 2 years, this risk will persist. So till 1 to 2 years, it is advisable not to use succinylcholine. So in the first 24 hours, it is safe. 48 to 72 hours after the burn, it is not safe, and right up to 1 to 2 years. Usually, all these effects, this resistance and high sensitivity to succinylcholine, are seen with 25% burns, but studies have shown even with 8% burns, these effects can be seen. So it is, nothing is really proven, but 24 hours it is said to be safe to use succinylcholine. 48 to 72 hours no, up to 1 to 2 years. So these are some of the diseases with altered response to muscle relaxants. So as you can see, hypersensitivity is seen with amyotrophic lateral sclerosis, uh, hyperkalemic periodic paralysis, Guillain-Barré syndrome, myasthenia gravis, myasthenia syndrome, and resistance, as you can see, seen in burns patients, cerebral palsy, and chronic infections like tetanus and botulism. Now I will be dealing with each individual drug. So again, like, I'll just again go to the classification chemistry. Benzyl isophenolium is atracurium, cisatracurium, vivacurium, doxycurium, and the older ones are your tubicurium, metacurium, galamine. The steroidal is your pancuronium, vecuronium, rocuronium, pipocuronium, rapacuronium. Now rapacuronium is also not used because it produced severe bronchospasm, because it acted on the M2, it blocked the M2 receptor, as a result causing bronchospasm. M2 receptor on the nerve, which led to excess release of acetylcholine binding to M3 receptor on the bronchioles, causing bronchospasm. As a result, it was removed from the market. Gantacurium is a newer non-depolarizing muscle relaxant. So coming to atracurium, it's a benzyl isophenolium compound. As you can see, this is the structure. It is composed of two. It is composed of two carbon separations between the quaternary. So these are the two carbon separations between the quaternary. This is a quaternary nitrogen compound. So there are two carbon separations between the quaternary nitrogen and the ester carbonyl. This is the site for your, as a result, because of this bonding, that is the two carbon atoms between the quaternary nitrogen and the ester, this is the site of degradation, which leads to your Hoffman elimination. Your Hoffman elimination occurs here. So basically your Hoffman elimination is it's just a chemical breakdown. It's a chemical breakdown because of this binding that is seen. So it chemically breaks down the quaternary ammonium to a tertiary amine, which is your laudanocin, which has CNS activating property. But in clinical doses, this adverse effect is not seen of laudanocin, and also it breaks down to another byproduct which is inactive. Atracurium has 4 chiral centers, which leads to it having 10 isomers. The 3 most common isomers are the cis-cis, cis-trans, and your trans-trans isomers in the ratio of 10:6:1. Your cis-cis is basically your cis-cis isomer is basically your cisatracurium. Now your so atracurium, it is a benzyl isophenol, belongs to the benzyl isophenolium group. It is intermediate acting. It releases histamine when administered rapidly or given 3 times the intubating dose. So basically histamine release occurs when it is during a rapid administration and when increased dose of atracurium. Normal doses, it does not occur. There is no histamine release with atracurium in normal intubating doses, and generally the clinical features are insignificant. So 3 times the intubating dose and any rapid. So basically this drug should be given slowly. Metabolism, like I said, it undergoes Hoffman elimination. It is pH dependent. It is stable. It is stable at a pH of 3 and stable at a pH of 3 and at a temperature of 4 degrees. So it should be stored in a freezer, and it undergoes degradation in the plasma. So in the plasma, esterases, so your bioesterases, that is basically the ester hydrolysis. So as soon as it is administered, it undergoes degradation in the plasma bioester hydrolysis. The metabolite is laudanocene, which is a tertiary ammonium compound, a CNS stimulant, but no effects are seen in in a normal clinical scenario, because the dose required is again many more times than even the infusion doses. What the metabolite that collects with infusion in the ICU is also not enough to cause this CNS stimulant effect. Very high doses are required to cause effect. It does not require any liver or kidney metabolism and excretion. Hence, it is generally safe in patients with hepatic and renal disorders. But the duration of action, like I said, in hepatic disorders is prolonged because of increased volume of distribution. Renal disorders, it is relatively safe to use. It is non-cumulative and hence can be given as an infusion. Now coming to the dosage and storage, onset is within almost all the neuromuscular blocking drugs, onset is within 3 minutes. Intubating dose is 0.5 milligram per kg, that is twice the ED95. Intravenously for intubation, it can be, and maintenance dose is 0.25. So basically maintenance dose for intermediate is intermediate acting non-depolarizing muscle relaxers is 1/4 the intubating dose, and for long acting is like Pancuronium, it is 1/10. So for this it is 1/4 the intubating dose, that is 0.25. Then infusion 0.5 to 10 microgram per kg per minute. Storage, it must be stored at 2 to 8. Basically, it is stored at 4 degrees Celsius. It loses 5 to 10% of its potency for each month it is exposed to room temperature. It should be used within 14 days when kept in room temperature. Side effects, like I said, dose-dependent histamine release. It is only significant at doses above the intubating dose, that is 0.5 milligram per kg. Okay, otherwise it is not significant. Hypotension and tachycardia. So basically your hypotension and tachycardia are basically caused due to the histamine release, otherwise it is not seen. Okay, so how can you prevent this histamine release is by a slow rate of injection. Bronchospasm, so it should be avoided in patients with asthma. Again, can cause bronchospasm. Again, this is your histamine release which leads to this bronchospasm, right? Then laudanocene toxicity. This is by cleavage of the quaternary ammonium compound, tertiary amine, that is laudanocene, is produced by Hoffman elimination. Central nervous system, it causes central nervous system excitation and can precipitate seizures. Laudanocene is metabolized by the, I'm sorry, it is not the liver, it is the kidney. It is metabolized by the kidney and it's metabolized by the, yeah, correct, metabolized by the kidney and the liver and excreted in urine and bile, but to a greater extent by the kidney. Temperature and pH sensitivity. Hoffman degradation depends on temperature and pH. So any increase in hypothermia as well as a change in pH will alter Hoffman degradation. So duration of action is prolonged by hypothermia and to a lesser extent by acidosis. Hypothermia plays a bigger role in the prolongation of the duration of action because it prevents this Hoffman degradation. As a result, it slows the Hoffman degradation. As a result, the duration will be prolonged. Atracurium will precipitate as a free acid if it is introduced into an intravenous line containing an alkaline solution. So basically, when given with thiopentone sodium, which is an induction agent, so if it is given in the same line, chances of precipitation will occur when it is introduced because this is an alkaline solution. Now, allergic reactions, again the allergic reactions occur because of histamine release. Anaphylactoid reactions can occur but are very, very rare because of immunogenicity or an acrylate mediate immune activation, but it is very rare. So acrylate is a metabolite of atracurium. Along with laudanocin, monoacrylate is produced. So this can lead to anaphylactic reactions, but it is very rare. Now, Cisatracurium, cis isomer of atracurium. It is stereoisomer. It is 4 times more potent. It is highly potent, 4 times more potent than atracurium. It undergoes Hoffman elimination like atracurium, but very important, but does not undergo ester hydrolysis. So there is no ester hydrolysis. There is no ester hydrolysis occurring. It does not produce histamine and laudanocin. It does not produce histamine. There is no ester hydrolysis, no histamine. Laudanocin production is 5 times less than atracurium. Okay. And again, because Hoffman elimination, hence metabolism and elimination independent of hepatic and renal failure, it does not have any autonomic effects, hence does not alter heart rate or blood pressure. So what does it share with atracurium? Basically the laudanocin production and pH and temperature sensitivity because of your Hoffman elimination. And what does it not share is there is no ester hydrolysis and no histamine release. So your dosage and storage, intubating dose is 0.1 to 0.15 milligram per kg. Onset is within 2 to 3 minutes. Infusion is 1 to 2 microgram per kg per minute. Should be refrigerated at 2 to 8 degrees Celsius and used within 21 days after removal from refrigeration and exposed to room temperature. Atracurium is 14 days. Now, Pancuronium is your long-acting steroidal muscle relaxant steroid ring on which 2 modified acetylcholine molecules are positioned. So it is a bisquaternary relaxant. It is metabolized by the liver to a limited degree. Only 15 to 20% is by the liver. Rest is all primarily by the kidney, 40%. Metabolic products have some neuromuscular blocking activity. That is the 3-hydroxy metabolite. It has 3 metabolites, but the most active is the 3-hydroxy. It is half as potent as pancuronium. Potency is half. It undergoes similar pharmacokinetics like pancuronium, and it is excreted in the urine, but there is no accumulation. So hence, anyways, doses, because the pancuronium major route of elimination is the kidney, so dose has to be decreased, and this metabolite also can accumulate, so dose should be decreased in renal failure. Cirrhosis may require a larger initial dose because of the increased volume of distribution. So the onset will be late with regular doses, but maintenance doses have to be decreased because of the decreased rate of plasma clearance. That is, some amount does undergo clearance by the liver. So in cirrhosis patients, initially the first dose needs to be larger because of the increased volume of distribution if a faster onset is needed. But maintenance dose has to be decreased because of decreased plasma clearance. Otherwise, there will be a prolongation of action. The intubating dose is 0.08 to 0.12 milligram per kg. Again, here the maintenance dose is 1/10. This is a long acting, so 1/10 of the intubating dose, 0.04 milligram per kg. Storage is at 2 to 8 degrees Celsius, but this is stable to for 6 months at normal room temperature. So at normal room temperature can be kept for 6 months. The side effects are hypertension and tachycardia. Tachycardia is known to occur because of vagal blockade by action on the M2 receptors and in the cardia, and sympathetic stimulation, that is catecholamine released from adrenergic nerve endings, and it decreases catecholamine reuptake, so it causes that hypertension and tachycardia. So basically when opioid, like I said, when opioid anesthesia is given, opioid, that is for cardiac cases, opioid anesthesia, large doses of opioid are used. This can lead to bradycardia. So basically large boluses of pancuronium. Pancuronium is given to counteract this bradycardia caused by opioid anesthesia. So it should be given in caution in patients in whom an increased heart rate would be detrimental, like coronary artery disease, hypertrophic cardiomyopathy, aortic stenosis. Pancuronium is contraindicated. Ventricular arrhythmias, so because of increased AV conduction and catecholamine release, it can cause ventricular arrhythmias. And a combination of pancuronium, tricyclic depressants, and halothane are arrhythmogenic, because halothane as well as tricyclic antidepressants both have arrhythmogenic activity. So a combination of all these is additive. Allergic reactions, hypersensitivity, it is pancuronium bromide. So any hypersensitivity to the bromides may exhibit a reaction to pancuronium. Now Vecuronium, the physical structure, it is basically pancuronium minus the quaternary methyl group. It is a monoquaternary relaxant. Yeah, not a bisquaternary, a monoquaternary relaxant. This minor change, so there is no methyl group. This minor change alters side effects without altering potency. Also, it is not water soluble because of this. It is metabolized to a small extent by the liver, and excretion is primarily biliary excretion. Only 25% depends on renal excretion, otherwise primarily it is by the liver. In the ICU, it has 3 active metabolites, basically vecuronium, and it's acetyl vecuronium, the metabolite. In long-term administration, it has 80% potency of vecuronium. As a result, in ICU, in prolonged administration, the neuromuscular blockade, it can occur up to several days because of this metabolite accumulation. And the risk factors are female gender, renal failure, and long-term high-dose corticosteroid therapy and sepsis. Dosages are equipotent, similar to pancuronium. Intubating is 0.08 to 0.12. Maintenance and relaxation is 0.04, followed by increments of 0.01. Women seem approximately 30% more sensitive to vecuronium. This has also been seen with pancuronium and rocuronium. This may be because of fat, muscle mass, protein binding, volume of distribution, but nothing is proven. On the side effects, the cardiovascular, no significant side effects. The liver failure, the duration of action is not significantly prolonged, but again the volume of distribution is increased, so initial larger doses need to be given, followed by lesser doses because of decreased clearance. Now rocuronium, it is a monoquaternary steroid analog of vecuronium, rapid onset of action. It is 6 to 8 times less potent than vecuronium but has the same molecular weight. Their metabolism is primarily by the liver, very slightly by the kidneys. So again, prolonged by severe hepatic failure and pregnancy. Elderly patients, like I discussed, because of decreased liver mass, duration may be prolonged. Renal disease not significantly altered. It does not have any active metabolites, and hence it may be the better choice for infusions in ICU. Now for intubations, the dosage is 0.05 to 0.9 milligram per kg intravenously, and boluses is 0.15 milligram per kg. Intramuscularly also it can be used. These are the doses intramuscularly: 2 mg per kg for children and 1 mg per kg for infants. Infusion requirements range from 5 to 12 microgram per kg per minute. Side effects are, it is an alternative, it is not a side effect, but it is an alternative for rapid sequence intubation, that is within 60 to 90 seconds. What is achieved with scoline can be done with this too, with a dose of 0.9 to 1.2 milligram per kg. At these higher doses, within 90 seconds the trachea can be intubated. However, the duration of action will be prolonged. It is the drug of choice for precurization. That is a small dose is given before succinylcholine, so that it prevents the side effects of succinylcholine. Drug stimulates little histamine release or cardiovascular disturbances, although in high doses it has a mild vagolytic property. There's not much histamine release, cardiovascular disturbances, or any vagolytic property. Tuberculin, it is a long-acting monoquaternary, excreted unchanged in urine and liver, is the secondary route of elimination. It is not indicated. It has a very long duration of action. It causes a lot of histamine release in normal intubating doses itself. There is histamine release, hence it is not advisable, and not indicated in renal or hepatic failure. Onset is slow, duration of action is very long, recovery is very slow. Basically, this drug is not used anymore, but I have just put it here. Now coming to the newer muscle relaxants, Gantacurium. It is a class of chlorfumarate. It is provided as a lyophilized powder because it is not stable in aqueous solution. Like Vecuronium, ultra short duration of action, similar to that of succinylcholine. Another one is your Rocuronium with an ultra short duration of action. It undergoes non-enzymatic degradation by two mechanisms. That is, it forms a inactive cysteine adduction product and ester hydrolysis. There is no active metabolite. So cysteine adduction and ester hydrolysis are the method of degradation. Dose is 0.2 milligram per kg within 1 to 2 minutes onset of action, and duration of blockade is same like succinylcholine, around 9 to 13 minutes. Its clinical duration of action ranges from 5 to 10 minutes, and recovery can be accelerated by edrophonium or exogenous cysteine. Cardiovascular effect, histamine release is followed. Again, 3 times the intubating dose leads to histamine release. These are in brief about the other ones. They are not required. Rocuronium, like I said, because of bronchospasm, was removed. Galamine causes the most potent vagolytic properties of any relaxant. And metacurium, patients allergic to iodine like shellfish allergies could exhibit hypersensitivity to this because it contains iodine. Mivacurium is a short acting. It is a benzyl isophenolium derivative metabolized by pseudocholine esterase. This is important, like your succinylcholine. Duration of action may be prolonged when pseudocholine esterase levels are low. Intubating dose is 0.2 milligram per kg. It releases histamines to the same extent as atracurium, that is 3 times the intubating dose. So how can you minimize the cardiac effects? By slow injection, so that histamine effects are not seen. It is used particularly for surgical procedures requiring relaxation, in which atracurium and vecuronium too seem too long. Okay, but we have rocuronium, which there is rapid recovery too, which can be used instead. So basically, vecuronium is used for bronchoscopy, esophagoscopy, laparoscopy. Now, doxycurium, primary route is renal excretion. It is long acting, devoid of any cardiovascular and histamine releasing side effects. Pipocuronium, without vagolytic effects, steroidal. It is a steroidal compound. Onset and duration of action are similar to pancuronium. Elimination primarily through renal and biliary. So some of the clinical characteristics of non-depolarizing drugs, basically your intubating doses, onset of action, duration of intubation, maintenance doses, and maintenance doses by infusion. So guys, this was briefly about this was the remaining class on the non-depolarizing muscle relaxants, and I dealt with the drug interactions, the each drug in detail, and also some of the I briefly about the previous class, the drug interactions, about each drug and the effect on the various population groups as well as various disease states. My next class will be on the neuromuscular monitoring, that is how so after paralysis, how we will deal with how we know when to reverse the patient, get the patient out of paralysis. So there are certain monitors that need to be used to know the adequate time of reversing, bringing these patients back from the paralyzed state. So that is neuromuscular monitoring, which I will be taking tomorrow at 7:30 p.m. Guys, also please do subscribe and also access our special classes where you have free access to them, and do subscribe. Use my code, like I said previously, use my code Sasha, SASHA, use my code Sasha and get your 10% discount. So guys, subscribe quick, quick. Okay guys, that's all for today. Thank you, have a great evening.